So the first patient is a 67-year-old female. She was recently confirmed to have a cervical adenocarcinoma. It was a cervical biopsy, and they were confirmed to have adenocarcinoma from the cervical biopsy, and it was HPV negative cancer, and it is likely a clear cell adenocarcinoma. Unsure if it's coming from the cervix or it is coming from the cervical involvement of the endometrium cavity. So in this urine specimen, we do see a lot of inflammatory cells in the background. However, we also see these highly atypical cells with abundant bubbly cytoplasm. So it is compatible with the morphologic feature of a clear cell carcinoma. They were kind of scant cells, but indeed it's highly atypical and diagnostic for malignancy. For the origin of these tumor cells, it can be coming from the shedding of the lesion from the gynecologic tract, or it can also coming from the direct invasion. When we see direct invasion, usually we will see more necrotic background. In this case, we only see inflammatory cells, so it is a little bit uncertain if this is coming from the shedding or it is coming from the invasion. But we do see malignant cells here, so it is kind of unusual because we rarely see non-urothelial cancer in the urine specimen. So this is one of the example. So we move to a couple body fluid. The first case is a patient with a past history of lung adenocarcinoma. So in this specimen, we do see very scant but highly atypical cells, which is compatible with recurrence of the adenocarcinoma. The next specimen is coming from I think it's from ascites, from a patient with a past history of pancreatic cancer. The patient is actually coming from the other hospital with the history. So this is actually the patient's very first specimen in our hospital that we were told from the outside medical record that she had the adenocarcinoma of the pancreas. So in this body fluid specimen, we do see, comparing to the prior pleural effusion specimen, that we see more high-grade adenocarcinoma with larger, like gigantic tumor cells. Usually for the pancreatobiliary tract adenocarcinoma, the cell can be much smaller, but with a very tight cluster and a prominent luminal border formation. So this is compatible with the morphology of pancreatobiliary adenocarcinoma. So it seems to be that the patient already had like a peritonean seeding. So there won't be any surgery for this patient. She needs to receive systemic treatment for chemotherapy. So because this is the very first specimen to confirm the condition, so in our hospital, so it is important that we to be 100% sure. So the next specimen is also coming from a patient with lung adenocarcinoma. So again, this is kind of similar to the prior specimen, that in the pleural effusion, we only have very scattered but the gigantic, highly atypical cell. So this is compatible with recurrence of poorly differentiated adenocarcinoma. You can see the difference in size of a normal mesothelial cell or histiocyte or a lymphocyte. So the nucleolus is even bigger than the lymphocyte. So this is definitely malignant. Before the Chinese New Year, it seems that we have a lot of patients coming for small cell carcinoma. So again, this is a new patient. She's a elder lady, 80 something, but she is a heavy smoker, which is very important for the diagnosis of small cell carcinoma. So like we like we saw yesterday, that the small cell carcinoma can be sometimes tricky to identify in the low power. So in this proteinaceous background, you only see a few more hyperchromatic cells with almost no cytoplasm in a molding pattern. So here is also nuclear molding. Again, you see nuclear molding. Comparing to the adjacent lymphocytes, the nuclear is big. However, it can be at a similar size to an mesothelian cells, or can be slightly bigger. So in the cell block preparation, we saw this like Indian fire pattern. So this is a patient of small cell carcinoma with pleural effusion involvement. So the next case is a CSF specimen. Again, in the CSF, usually there's no cells. The patient had a past history of breast cancer. So despite these very bland looking, like a morphology, because its own presence is very unusual, because supposedly there should be no cells. And the nuclear, there is no reference in the background, but it's actually bigger than the usual size. So this is compatible with metastatic breast cancer. So here is a more tight cluster. And it is usually much easier to see the contrast in the loose stain. The staining is very light, but we do see these mononuclear cells with relatively large nucleus. So this is compatible with metastatic breast cancer. The next specimen is from a pleural effusion. Again, the patient also had a history of breast cancer. In this specimen, we see mostly tumor cell. There are some very, very big cells, but the other cells in the background is also cancer cell. They are all very big. So this is the normal size of lymphocytes. So you see these polymorphic epithelial cells in the background with almost no mesothelium. So this is also positive for metastatic carcinoma. So the next specimen is coming from a patient with history of lung cancer. Again, it is a pleural effusion specimen. So again, not many cells, but we do see scattered larger cells. So these three patients are all like a recurrence with a high-grade polydifferentiated morphology. The next specimen is also a CSF specimen. A 54-year-old male. So in this specimen, we also see scattered cells, mononuclear, with relatively large nucleus and very irregular, like a chromatin or nucleola, and with a plasmacytoid feature. So here we see another cells with a similar morphology. So when we check the history of the patient, he is actually a patient of plasma cell myeloma, multiple myeloma. So in these CSF specimen, we do see a typical plasmacytoid cells. However, when we are more like a definite, more confidently diagnosed of multiple myeloma in the CSF specimen, usually we would like to see higher cellularity, like the other lymphoma involvement of the CSF. In this specimen, I would just say the cell is highly atypical, but it is very, very scant. It's a little bit unusual for the involvement of hematologic malignancy of the CSF specimen. So I decided to call these suspicious, and we see these highly atypical plasmacytoid cells. And it is likely compatible with involvement of plasma cell myeloma. The patient also received light chain analysis for the CSF specimen, so it shows that shifting to the kappa light chain with a very high level in the CSF. So this is likely that is involved by the plasma cell myeloma. Just in the cytology specimen, I think the cellularity is very scant, so it's better that we just call it suspicious. So the next specimen is lung aspiration cytology with direct smear. It is kind of unusual to see this type of like a specimen. In the background, we see a lot of nuclear debris, like choreresis pattern, engulfing in like foamy cells, so likely histiocyte, macrophages. So we have this unusual background. In some of the area, we do see more aggregation, like a solid sheet of cells arranging in a glandular or rosette pattern. Some of the cell does have like elongation with stratification palisading pattern. So this actually looks more like intestinal type glandular cell. So when we check the history, indeed the patient does has the history of colon cancer. So I think this can be a metastatic colon cancer, and possibly the patient has received certain treatment. So there are some striking treatment response in the background with nuclear like choreresis. Because it is not uncommon that we see the metastatic colon cancer specimen. Usually we will see with a very dirty necrotic background. It is not present here, so it is kind of unusual. Instead, we do see these choreretic background. So certain chemotherapy agent can actually induce this type of changes. So I think we do still have metastatic adeno because we see these typical morphology for colon cancer. So we will check the concurrent biopsy, but this is highly likely just a metastatic lung adenocarcinoma. So the next specimen is coming from a patient with history of breast cancer. This is a bone aspiration. So in the usual bone aspiration, we will see the bone marrow element, so which looks like this. So heterogeneous mononuclear inflammatory type of cells. In this specimen, we start to see there are some unusual like cell aggregates with high-grade atypia and prominent nucleolus. So this is compatible with metastatic carcinoma. We do see some more at the periphery. So again, this looks like carcinoma. So due to the history, it is compatible with metastatic breast cancer. The final specimen is a pap smear. So the patient has a past history of CIN2, possibly long time ago because I cannot find it in our system. And the patient has been followed in our outpatient department for a couple years. So in this specimen, this is a 52-year-old female. We do have a lot of superficial cells, a bit unusual for the age. The screener do highlight a few cells with very like a bigger in size compared to the superficial cell, high NC ratio, hyperchromasia. However, the cell itself is a little bit degenerative because you can tell by the nuclear contour, nuclear membrane, it is a little bit beating, right? And the chromatin pattern is actually degenerative instead of like a unequivocally like a well-preserved coarse chromatin. So the cell looks atypical, but it is very, it's not like a definite for a high CO cell. So we have a few of these atypical looking cells with degeneration. So I'm uncertain where is this coming from. Is it a squamous cell or is this just a like a shedding degenerative cell? I have no idea. We do see a few intermediate cells with slightly increased NC ratio and nuclear size, but without coelocity change. So again, some intermediate cells increase in size and increase in NC ratio. However, the chromatin pattern is a little bit loose, so it is also not very definite for a high CO cell. So we have a few atypical cells with higher NC ratio, enlarged nuclear size, but without definite like a chromatin pattern and the other feature. So I think the case is actually qualified for the diagnosis of Ascus high, cannot exclude high CO. Again, we see a like a higher NC ratio cells. However, I just find the cell doesn't, the chromatin pattern does not like very clear. It seems to be degenerative, and the cellularity is very scant. So it is better that we just call it Ascus high. Instead, we call it high CO directly. So this is, I decided to call it Ascus high. Okay, so that's all the case for today.